All right, welcome everybody to our last ASVNU Journal Club session of the year. It is fantastic to have everybody in attendance. Hope everyone had a great beginning of their fall and wish everyone a happy holiday season coming up. I'd like to thank Jethro for leading our discussion today in fluid therapy for patients with kidney disease and how it relates to volume overload. Just as a reminder, as always, feel free to write any questions you have in the chat. The chat should be at the very bottom of your menu bar, or feel free to unmute your microphone and to ask the question as we go. We certainly always want these rounds to be more of a discussion rather than a lecture. So we encourage that. And again, thanks, Jethro, for getting us started with this session. And I will mute myself and then turn it over to you. Thanks so much.
All right. Well, thank you, and thanks for being here, everyone, on a nice Friday in December. As JD said, my name is Jethro Forbes. I'm currently up at Cornell University on the faculty with the Emergency and Critical Care section. Before everybody kind of turns off their screen and logs out, I do have a lot of relationships with internists as well, and in fact, I'm married to a veterinary internist, so she keeps me in line and makes sure I don't stray too far from, I think, the principles of ACVIM when we're doing some of our renal discussions and extracorporeal therapies. I am currently, as I said, I'm at Cornell, but I've been around the block a few times here. From the Northwest, picture of Seattle up there, to Colorado, Ontario Veterinary College, California, all up and down the West Coast. And these are my two kids on here. Hamlin is almost 3, and Skylar down below there is almost 9. These are some older photos, and time flies. We live just outside of Ithaca. We've got a couple dogs, some horses. That's our farm down below there. And yeah, we're just trying to do our thing here. I'm excited to announce Cornell just gave me the go ahead to put the final purchases on extracorporeal equipment. So we'll be growing and expanding that service here as well. So my goals for today, if I'm honest and selfish, I'm really hoping to learn something from you guys in this, and hopefully I'm gonna be able to close my mouth long enough at a few different points in time in here to actually give some opportunity, some space for you guys to jump in and tell us about what you do in your practice. But I do want to initiate this discussion of the fluid prescription, and I really try and be mindful of using that nomenclature when I talk about fluids, because fluids are a drug, and I teach my students and residents and interns and anybody who will listen that we probably need to be a little more mindful of how we use that drug. Because there are detrimental pathological consequences of excess volume when we're treating kidney disease. I'm hoping also, as I said, to share some approaches used across different centers, identify ways and talk about ways that we evaluate fluid tolerance versus overload, and how we advance efforts to educate our colleagues on the dangers of excessive volume administration. On the participation front, oh man, fingers crossed. This worked in my practice session this morning. I answered a lot of my own polls here. But if you've got a computer, well, hopefully you're all on a computer or a phone, maybe you can go ahead and follow these instructions and get loaded up, because we do have a couple of poll questions throughout the journey here today. And your interaction with this is hopefully going to be fun. So each poll question that comes up will have, I think, at least the text message instructions again. So if you don't get it this time, hopefully it shows up again. Give it one more second for folks to get that, and going to jump right into the first one. This is a little bit of an icebreaker. Hopefully this comes through okay. What is your favorite fluid? This is a free response, so you should be able to just type in an answer. And I'm going to see if I can join here as well. I don't see anything coming yet, so that might be an indication that I've not set this up as well as I was hoping. Oh man, nope. Right off the bat, this one didn't work. Hopefully the other ones have. I had this all set up and ready to go here. Hopefully you guys all put in something here. What I was hoping to get out of this was maybe we talk about some crystalloids, some colloids. Maybe we're talking about, I typed in beer for mine. So I was hoping to have a little bit of a icebreaker there with that one. We sent out this recent article Drs. Langston and Gordon put out in Frontiers, the effects of IV fluids in dogs and cats with kidney failure. And I don't know if you'd already read it or had a chance to read it from JD's email. Let's try this one more time and see if I'm worried I might not have set this up as well as I wanted to, because I just put in another answer too. This will be a technology blunder here if this doesn't go. And it doesn't. All right. Well, ignore the rest of the questions as they come through. Apologies for that. They did work in the dry run earlier today. So, talking about, a lot of as a criticalist, a lot of my focus is on acute kidney injury, but I've certainly managed the fair share of more chronic, and as we get into the acute kidney disease after the injury in that first 90-day period, I'm certainly kind of my wheelhouse there. But we do recognize in that insults in the acute kidney injury that there's an initiation. There's some inciting events. A lot of times it's hypoperfusion, ischemia, toxin, what have you, across the board, leading into an extension phase where there's ongoing damage to the kidneys. So initiation phase results in tubular epithelial cell injury. The extension phase, continued hypoxia, inflammation, cell necrosis, apoptosis, and decrease in function and GFR over that time. Usually, when we start to see increases in biomarkers, as weak and as they are, serum creatinine being one of the big ones we follow. And then that maintenance phase where we're kind of waiting for things to heal if they're going to. We're giving the kidneys a chance to exist in an environment that hopefully we're managing in a way that's supportive, so that we can see some regain of function through cell repair, proliferation, redifferentiation after the dedifferentiation that happens prior to that. And hopefully, if we do right and we support and treat the underlying causes, if we're able to, we'll see some recovery phase in all this. We are likely all familiar with the Irish AKI grading scheme, so I can't have a talk like this and not have this in here just for background sake. And I think it's important to recognize the phases that I touched on, as well as the grading system, because our goal, my goal anyway, I'll put that in terms of me, my goal in these cases is, one, of course, to treat the underlying disease, but two, don't make it worse. And if I can recognize that there's been an insult in that initiation phase, then maybe I can set up the kidneys to be protected enough that the extension phase is less severe, less dramatic, and maybe that downward spiral of function getting into the maintenance phase is maybe there's a better retention of GFR and function if I can kind of hold back on making things worse. And so it's our opportunity to intervene when we might be at reversible stages of injury. We want to prevent and correct hypotension. A lot of our pets come in volume depleted. But at the same time, and this is the focus of a lot of what you're going to see through today, we want to avoid fluid overload and avoid nephrotoxic drugs, and think really long and hard about contrast-induced acute kidney injury if we're needing to do advanced imaging. Identifying at-risk patients and preparing at-risk patients for anesthesia. Some of our acute kidney injury patients come in for other issues that require a surgical intervention, for example, in anesthesia. So we want to try and prop these kidneys up as best as possible. And hopefully what we're looking to do is, recognize that there's dysfunction with that initial injury phase. We might even get into some structural damage and that altered function. And if we can pull back and bring these guys back from the brink here before hitting failure, maybe we can enact some protective measures to prevent the scarification of the kidneys or progression into CKD from stage 1 into stage 2, 4, or complete stage death, and the need for more advanced interventions like extracorporeal renal replacement therapies. So we're really just trying to pull back from the brink here, and that's what I'm going to focus on when we talk about fluid prescription and the risks of managing kidney injury with an injudicious fluid prescription plan. So I'm guessing this one's not going to work either. So do you guys give IV fluid to your kidney patients? Yeah, of course. I was hoping somebody was going to say no and play the clown. That's usually my role, but I can't in my role today. There's a whole wealth of both evidence, research, as well as somewhat consensus statements and contemporary reviews in the human medicine world in nephrology and critical care on fluid management in kidney injury patients. And the goals that get repeated again and again based on what's been found in research is that we want to administer the minimum amount of IV fluid to maintain perfusion and oxygen delivery. Just treating shock anywhere, and we want to make sure that we're reestablishing oxygen delivery. It requires frequent reassessment in our aims to achieve and maintain euvolemia. There's not a set it and forget it. That's one of my favorite things to tell trainees is whatever we're going to do as far as a starting place in our fluid prescription, it's just a starting place. It's just that. We need to reevaluate and continuously reassess so that we can find the balance that we're hoping to achieve. It is a dynamic and individualized prescription if we're doing it well. And out there, one of the reasons that this stimulated an interest for me and I guess an urge to talk about it amongst a friendly crowd and folks that are hopefully we're most of us are on the same page here. But I think outside of the nephrology, urology, and some of the critical care community, I think there's a way for us to expand the awareness and the understanding of what this fluid prescription really involves in our attempts to try and reduce harm and do well by our patients. And we're talking about the prescription, just like with an antibiotic or an analgesic or whatever have you. We're talking about a particular drug, isotonic crystalloids. There's a number of different drugs within that class. So we've got the sodium chloride, the 0.9% sodium chloride. We've got the buffered electrolyte solutions, the LRSs, the plasmolites, the normosols. We've got our colloids, and this is probably the only place in here I'm going to touch on colloids. This isn't where I was hoping to have that discussion. Blood products and other. These are all drugs under the fluid prescription. And then we have some other things, some other products, the hypotonic crystalloids. And amongst all of these different drugs under the fluid prescription, we have varying electrolyte compositions, varying buffers, bicarb precursors, and different pHs and different acidifying versus alkalinizing properties as well. So it really is. There's so many different variables in a fluid. When we just say put that dog with kidney injury on fluids or cats, just from the drug perspective, there's a fair bit of selection that is helpful to put into this decision. We also have to talk about the dose in our fluid prescription. And once we pick the appropriate drug itself for our particular patient, our individual, and decide that the right prescription drug is there. Now we have to talk about the volume that we're going to give. How much of this drug are we going to administer over what period of time, what duration? And I'm going to touch on it was in the Frontiers article, the notion of ROSE, resuscitation, optimization, stabilization, and evacuation. It's a growing topic in human fluid administration papers and conferences. And what we often forget in our world, and it seems to happen in the human world as well, is that last phase, that evacuation or that de-escalation phase. And so we won't get to a lot of the de-escalation phase here, as much as I'm going to really try and focus on the initial dose and the optimization and stabilization phase of things. We have some patient variables that come into play here as we're making our decisions for fluid prescription, and being aware and considerate of a patient's lean body weight and dose adjusting based on that. We might be in consideration of the patient's body weight and health. We meet them and they're not at their ideal place. They might have fluid losses, or they might be in a catabolic state and have lost some mass as well. The duration of illness, how long have they been sick? What degree of hydration are we talking about they're behind, and how quickly or how slowly we're going to replenish that. always worried about concurrent cardiac disease, and the cardio-renal relationship is a pretty important one. We have to be aware of their ongoing losses and current as well as development of electrolyte derangements. So a lot of things, again, when we say let's put that kidney case on fluids, there's more to it than that. And I think, again, I feel like I'm probably speaking to the choir here and preaching to you guys when it's really outside of us. My hope after all this is that we have more of these conversations to better titrate and individualize our prescriptions. So let's talk about the goals of volume in kidney injury. And as I mentioned earlier, we want to correct volume deficits. We want to deliver oxygen. We want to treat shock, which is an inadequate delivery of oxygen to tissues, leading to anaerobic cellular metabolism, which is a great stopgap for a little bit of time, but it leads to ongoing hypoperfusion, leads to cellular death, which then grows and leads to organ dysfunction and/or organ death and potentially irreversible death. So we want to treat that pretty aggressively, and early on in all this, we do that with our volume prescription. We want to improve renal blood flow, GFR, get that oxygen going to the kidneys as well. This is all about the kidneys, but we want to get oxygen going to all the tissues in the body, and we want to hopefully maybe some of this volume that we're sending down the kidneys is going to clear some obstructive debris as those cells are going through their necrosis, apoptosis, and all the damage that's going on there. And as with a lot of elements in veterinary medicine, we are seeking to adhere to the Goldilocks principle. Not too hot, not too cold, just right. Not too little, not too much, just right. As we recognize hypoperfusion leads to ongoing ischemic kidney injury, again, don't make well, if we don't correct that factor, whatever the underlying insults, the initial initiating insult, may progress and may get worse. So we want to make sure we're doing no harm that way. However, on the flip side of that, hypervolemia, as we're going to talk about here today, also leads to systemic complications, organ function, or I should probably say dysfunction, including progression of kidney injury. So we're going to try and find that sweet spot, that Goldilocks. So that maybe as we look at this, stereotypical graph here of GFR over time with kidney injury, maybe we can keep things at that upper part of the extension phase, or maybe even just still in that initiation phase, and we don't get as bottomed out as we could. When we're talking about volume, there's a number of different factors that go into it. And I'm going to repeat something I said before and something I say on a daily basis, I feel, in the clinics, which is it doesn't probably matter. This is my approach. And, again, somebody jump in and cut me off here if you think different. It doesn't matter so much as where you start, as long as you're resuscitating and restoring intravascular volume in an appropriate manner. You'll see folks that incorporate a dehydration deficit, a maintenance, evaluation using one of a number of different ways that we, I'm doing air quotes over here, decide what maintenance is. Some folks include insensible losses in this calculation. We definitely have to be aware of ongoing losses. And so wherever we start with our fluid prescription, once we've resuscitated our patients, is probably not as important as how we adapt and adjust based on what our patient's telling us. So I work in a clinic where we've got a number of folks that use the allometric or RER kind of based equation for developing a maintenance rate of a crystalloid, and others are in the 40 to 60 mils per kg per day camp. And again, we have conversations and we talk about, all right, well, let's find our starting place, and then we adjust and modify from there. You know what? I'll go back here. This is a still shot of a very fluid focused experience here. It's my son Hanlon in our backyard there with one of our dogs, Winter, and it's one of the horse buckets they were filling up there for refilling their water for the day. And the two of them were splashing each other essentially. Winter, our dog, was shoving her head in there and shaking it around. Hanlon was splashing up in the air, and she was trying to attack the splashes. And it's a great still shot here, but the action behind it is lost in this still image instead. But that's them. They're both pretty silly kids there. So as I said, we want to find that balance of hypovolemia and hypervolemia. Where's that Goldilocks, that middle spot? In the hypovolemic stages, we've got altered tissue perfusion. We've got, and this is out of a human medicine source here. We know all the decreased delivery of oxygen to tissues and all the ongoing ischemic damage that causes. We also see on the other end edema formation in tissues throughout the body, respiratory failure, impaired healing, altered mobilization, multiple organ failure. And so there really is a sweet spot, and we can't give fluids to excess and just think that we're going to get away with it. Although in health, the kidneys in our patients, our cats and dogs, do an amazing job of tolerating the fluid prescription that we impose on them on a daily basis. But we're talking about kidney disease where they don't necessarily have the reserve capability to do that. So this is the newer concept, principles of fluid management, and a lot of the focus is in cases of septic shock. So that's where a lot of patients get volumes and liters upon liters of crystalloid therapies for resuscitation efforts. And it really is important that they get that in the resuscitation phase, that R phase there, and the cumulative fluid balance on the y-axis over time on the x-axis is important to know that we've got to restore volume in these guys. And then at some point we do have to consider where is that plateau of optimization and stabilization. And that's going to be an important consideration, because if we continue on this upward trajectory, hopefully the arrow is coming through on my mouse here on the screen, but if we continue on that upward trajectory, we're going to overload these guys considerably and often detrimentally as well. Over time, we need to look at getting back to that evacuation phase, and that's often much later, and probably often when we send our patients home, as well as when people are discharged from the hospital. There's the evacuation phase. But sometimes when there's an overshoot here and our plateau is much more I guess extreme on the positive fluid balance, the evacuation phase in human medicine has been acknowledged to include the administration of drugs like diuretics to try and evacuate volumes, to try and get patients on a more appropriate plateau for that phase of stabilization. And sometimes it's give and take, and it's up and down a little bit. And we'll see that in our veterinary patients as well. I certainly see folks that push and push and push in kidney cases and overload these guys. And we'll talk about the detrimental effects of edema in the kidneys as well as other tissues. And we end up reaching for something to try and remove some of that excess volume and to initiate that evacuation phase, try and restore urine production in most cases in our animal patients. This is just a quick slide to say there is no shortage of evidence coming out of human literature to say that fluid excess is detrimental to outcomes and contributes to morbidity across a number of different patient illness categories. Positive fluid balance is associated with worse outcome in patients with acute renal failure. That's down on the right there at the bottom. A lot of the studies are in septic patients or critically ill patients, but needless to say, across the board, there's a good body of evidence to say that fluid excess and a positive fluid balance is not necessarily a good thing. And in fact, I should say that a little more firmly, it is a bad thing. This is just a summary of a meta-analysis saying the same thing. If you look at the forest plot down here, you can see that pretty far across on the right there, that the cumulative findings in these 6 studies or so find that the odds ratio, and this is for morbidity as well as mortality outcomes, favors more volume control as opposed to fluid overload. So just kind of a summary of all those papers I had up a minute ago. You've seen this. We want to find the sweet spot, Goldilocks. That's in there again. So what happens at the level of the kidneys? What is some of the problem and some of the things that maybe don't get thought about all the time? Well, when we increase tubular flow with excess volume, and we'll talk about chloride maybe 10 slides from now, and we'll come back to tubulo-glomerular feedback. But that is a indicator or a message for the kidneys to decrease flow when they're getting too much. Their autoregulation, as you all know, is an amazing intrinsic power of the kidneys amongst all their other superpowers. And we'll circle back around to that one. But I wanted to touch on the kidney swelling within its capsule or their capsules from interstitial edema. And I put it, with my trainees, I put it in terms of everybody understands when you've got increased intracranial pressure and you've got a cranial vault that has an inability to expand. And though the kidneys aren't housed in a skull necessarily, they are in a capsule, and it's got fairly limited ability to stretch and grow. And so as the kidney interstitium inside that capsule swells with edema, we can see that there's decreased renal blood flow from congestion, which decreases GFR. All these things that we're trying to enhance and trying to support the kidneys through the injury phase. We see a congestive nephrosis, and venous return is impaired. We see impaired oxygen transport. We can see tubular obstruction from all this, and ultimately, and this is not uncommon, oligoanuria or worsening azotemia because of the excess fluid that's accumulated in the kidneys. Outside the kidneys, I've put intra-abdominal hypertension because that can also increase pressure on the normal structures in the kidneys as well. And so edema throughout the abdominal cavity can also be detrimental. And I am so thankful that Drs. Langston and Gordon put this dog in their paper, because it has replaced all these silly people, human pictures that I've had to use in my presentations all along here. And it's a really simple, beautiful kind of pictorial here of what happens when we put excess crystalloid volumes or fluids into our patients. I can put anybody on the spot, student, intern, resident, myself, colleagues, otherwise, and say, what are some signs of fluid excess and overhydration or volume excess? And they can point to the serous nasal discharge and chemosis and peripheral edema, maybe even the pulmonary edema. Those are pretty obvious things that I think are ingrained in our training of veterinarians. Some of those are later indications, though, and by just focusing on those things, I think there's a danger in missing where else this fluid is accumulating before it becomes externally apparent. So I've touched on all the kidney effects of that, and we're going to continue that conversation as well. But let's not forget about the gut. A lot of our kidney patients are nauseous. They've been vomiting. They've had diarrheal losses. There's already an ileus that we're combating with medications and trying to get back on track, help them get some enteral nutrition in or water on board and reduce losses. Well, our gut is certainly susceptible to edema collection in the layers of the intestines and the stomach. And as that edema continues to accumulate there, we get malabsorptive disease. We enhance or make ileus worse. We make nausea worse. We have collection of fluid within the GI lumen. Tissue edema contributes to poor wound healing, pressure ulcerations in our down patients. We see a lot of potential effects in the liver as well, with impaired synthetic function, cholestasis. The heart doesn't get enough credit in all of this as well. We see conduction, or we can see conduction disturbances, not just from the electrolyte abnormalities that we're all familiar with, but also with edema of those myocardiocytes. The lungs, everybody's pretty aware of that as well. But impaired gas exchange, tachypnea, labor breathing, things that don't help our situation. And then don't forget about the brain as well. A lot of our patients are pretty dull, depressed, or otherwise mentally affected. But if they're hypoperfusing their brain and not getting enough oxygen delivered, that's a bad thing. If they have cerebral edema, that's also a bad thing. And so we're also needing to be more aware of those consequences of fluid extremes. In terms of the kidney itself, I kind of touched on some of these things, but excess fluid in combination, there's a lot of inflammation that goes on in the body in acute kidney injury, as well as, I see a lot of septic patients and a lot of patients that have a lot of reasons to be hyperinflammatory or pro-inflammatory. And it can lead to a combination of hypovolemic shock as well as distributive shock. characterized by vasoplegia and leaky capillary endothelial barriers to fluid staying within the intravascular space. And cardiogenic shock can be a part of this as well. As we start to fill up those kidneys with edema, we get a decrease in arterial perfusion, so decreased oxygen delivery. Oh my gosh, well, that's not good, obviously. Decreased venous return getting out of the kidney, and decreased tissue oxygenation. And there's an ability, the natural, flow for clearing edema is meant to be through lymphatic drainage and or venous drainage as well. And as we crush those lymphatics with their thin walls in the kidneys and elsewhere in the body, squeeze them down with accumulation of fluid and edema formation, we impair the escape mechanism that's in place there to try and prevent all this bad accumulation of edema. This is an interesting murine model, and I think excuse me, it's well, let me give kind of the overview here. They took these mice and they clamped off, obviously in the sham they clamped nothing off. They clamped off either the renal artery, the renal vein, or both artery and vein. And they did this, these are the 30-minute clamps, mice. And 24 hours later, they allowed reperfusion and ischemic injury to take place. And 24 hours later, they looked at Doppler blood flow to the kidneys. And this I found really interesting. So you see the sham, so these are normal Doppler blood flow to the kidney there. You see in the renal artery, it's diminished. There's certainly less flow for sure. Look at the difference between when they clamped the renal vein here and they caused a congestive nephrosis. It's even more profound, the impairments of subsequent renal blood flow and perfusion after a venous congestion, which is what we're doing when we create that interstitial edema with fluid excess administration in our prescription. Obviously, when they clamped both artery and vein, those kidneys were in pretty rough shape as well. Interesting, kind of here's some visual to put to the venous congestion is bad, and the venous side is something, and the fluid collection on that side, along with edema, is something that is something to pay attention to. It's not all about the arterial side. So as we're talking about congestion, and we're talking about delivery of oxygen to those tissues, and the impairment that comes from venous congestion and all the rest of that, we also recognize that Fick's law of oxygen diffusion says that the oxygen diffusion between two compartments, and we're talking about the bloodstream and the arterial flow, and the renal tissues themselves, and the tubular cells, and all the rest of the interstitial tissue. Well, oxygen diffusion is affected by the gradient between the capillary and tissue. So we've got to get some oxygen going on those red blood cells so that there's a gradient to drive it into the cells. But the diffusional distance is also a big player here. And I think you'll see that in this pictorial here on the far. There's a whole lot going on this slide, but I'm really just going to draw your attention to the lower right hand corner here. Whereas interstitial edema starts to form, we see an increased distance for oxygen diffusion taking place here. So again, by overloading these kidneys, we're also increasing the distance that oxygen has to try and diffuse to help maintain oxygenation in the tubular cells. And that's just going to contribute to worsening of injury as well. So again, it's a matter of trying to do no harm, trying to provide a supportive environment for these kidneys to heal and recover, and the definite risks of us doing harm by being overzealous in our fluid prescription in terms of volume and collection of edema that forms. It's man, we can have hours on hours of discussion of the endothelial glycocalyx, but needless to say, just a brief overview. It's over the last 20 years or so, there's been a whole ton of investigation and research and findings that have identified this almost like a brush border layer on healthy on the healthy endothelial cells in vessels throughout the body. And there's a revised Starling's forces equation now that takes that into account, that the plasma proteins that are bound in this glycocalyx layer actually help form some of the onconic pressure to retain volume within the intravascular space. And in damaged glycocalyx models, that endothelial barrier, which is enhanced by the glycocalyx layer, becomes incompetent and leaky. And so as much as our 75% of a crystalloid will redistribute out of the intravascular space into the interstitial and eventually into the intracellular spaces and distribute amongst total body water, that is made worse when we have a damaged glycocalyx layer. Now, the glycocalyx layer can be damaged from inflammation and a lot of other parts of the disease process in a kidney injury that is present as well. But it can also be damaged by the effects of volume expansion. Volume expansion triggers the production of ANP from the atrium. And ANP is actually, it degrades the endothelial glycocalyx. I won't call it toxic, but it is damaging to it, which leads to injury and denudation, denuding of the endothelial glycocalyx layer and barrier failure. And so that's just kind of what I said there. So we're going to enhance extravasation of crystalloids and other fluids from the intravascular space into the interstitial spaces of the kidneys, leading to further development and worsening of interstitial edema and all the downstream effects that we talked about with that, and all the other tissues in the body as well. Oh, that's a slide I meant to take out there. I apologize. Let's talk about fluid balance a little bit. Because there are some veterinary studies, fortunately, a small handful, that have looked at the effect of cumulative fluid balance on outcomes. There's a whole bunch of them in the human end of things that I've shared earlier on there. But when we're talking about cumulative fluid balance, and I'll ask you to picture that Rose model again, that resuscitation, optimization, stabilization, evacuation graph. As we're going up the steep side of that slope, we're talking about fluid accumulation in excess of fluid removal or fluid out. And that makes some sense. We've got to put more in at the start because we're meeting a patient who is behind in their volume status. But that percentage of fluid accumulation, which is defined in a couple different ways, this is kind of the frustrating part of this literature, is in the human end of it, what that baseline is, where's the starting point, is somewhat of a moving target, and in the handful of veterinary studies as well, it's a little bit of a moving target. Is it walking through the door, their baseline body weight that's used? Is it the first drop of resuscitation fluid our human patients get in the emergency department or in our emergency department for our cats and dogs? Or is it when they're admitted to the ICU, which in a lot of the human studies, it becomes that baseline at admission to the ICU? We're talking about the body weight they use to calculate how much they have accumulated over time. The total volume out is a challenge unless you've got some urinary indwelling catheters to really document exactly how much is coming out. So we're left with estimating some of these things. But essentially, we're looking at the sum total of fluid accumulation over a set period of time, so either hospitalization or over 24 hours. And that percentage of fluid accumulation from baseline is the number to pay attention to. So the cumulative fluid balance divided by the baseline body weight, whatever point in time you decide that to be, times 100%. And 10% across the human studies is that line in the sand, fluid excess of 10% or overload of 10%, so more in than coming out by 10% or more, is that line in the sand where morbidity and mortality go up and outcomes decline. A handful of veterinary studies have looked at this as well, and odds ratio for death in this retrospective evaluation of fluid overload in critically ill dogs. Odds ratio goes up almost a little more than a point for every % increase in fluid overload during hospitalization. So 10 points for 10%, which would then be in line with where the human cutoffs are. Small case numbers here as well, but development of fluid overload in cats with urethral obstruction, increased cost and length of hospitalization. It didn't have an effect in mortality that was noted. And somewhat in line with that, this is a more recent JVIM article, talked about hypertension on admission. And this was I believe this was at a tertiary veterinary facility. So a lot of these patients had been on fluid support. These were kidney cases prior to being referred, but a good percentage of them came in with systemic hypertension and fluid overload. And there was an association between the two factors there. And survival was also negatively associated with fluid overload. So again, we don't have a ton of the body of evidence in our veterinary studies. Lots of room for people to kind of take that on and document that. But there's enough to say, hey, in conjunction with what we know from human fluid overload papers, that it's not a good thing. Avoid fluid overload. I'll take a quick drink of water here, speaking of fluids. And maybe this is a fair place to pause for a minute and just see if anybody has any questions, either in the chat or out loud, or comments, concerns. Tell me I'm crazy. Fluids are amazing. Crystalloids are the best. Give. I don't know if that beep was somebody leaving. Was it that bad already? Well, jump in anytime. Feel free to speak up. I wanted to, I don't think this is going to work just like the other ones didn't. But I mean, there's a number of different ways that I think maybe we bear some responsibility as folks with a focus on nephrology, urology, and love of the kidneys. And our own awareness can lead to sharing that awareness with folks out in our profession as well. I love ultrafiltration in kidney cases and extraportal therapies, and it's so amazing. You know, I share the story of the one dog we did a single treatment on and pulled a good volume of the fluid excess off, and she converted from an oligoanuric kidney injury patient to a polyuric phase, and we only ever had to do that one session. And the others, you know, as those of you guys doing renal replacement therapy can attest to, you know, pulling liters off of these big dogs, and we resolve that interstitial edema in the kidneys, and they regain urine production, and just an amazing thing. And that's kind of the I guess the formative experiences that have led to me getting on this soapbox seemingly on a daily basis. And you know, part of my mission is to get out there and educate our colleagues, to pull back a little bit. It's okay. More is not always better. And maybe we can work on some multi-institutional, multi-site research and kind of make some good arguments and a body of evidence to support our all of my soapboxing, I should say. This ends up, I've got, every time I do a presentation, I've got a couple of things that end up in my presentations, and this is one of them. I'm not sure if it's a little bit too small. So in my spare time, because I've got a lot of that, I'm a volunteer firefighter and have been for the last 4 or 5 years now. This was me going through the Firefighter Academy here. And I will say it was not a warm and fuzzy environment to learn and grow. And, you know, that there's reasons for that. But this picture kind of sums up my experience in firefighter training. Is if you can see the small words on there, it says "Don't suck today." And I put this in a lot of my presentations for interns and students as well. And you know, I think we can be softer in our approaches and more kind to each other, and how we help train and grow, and opportunities to expand our clinical successes. So I put that in there as a, hey, you know, tough love isn't always a good thing, but I do want to, you know, pull that back into the fluids. And I think we can be a little more firm in how we recommend appropriate fluid prescriptions. This is also my place to say that, hey, in case you guys don't know, 80 to 90% of firefighters in North America, US and Canada, are volunteers. It's only in kind of the bigger centers, you know, DC or San Francisco, LA, New York City, all the places like that where they're paid firefighters. So if you have extra time on your hands, and I know that's probably a tough call, But communities are losing volunteers like crazy, and it seems that not enough people have time or interest in doing that. So if you live in a community with a volunteer fire department, I encourage you to reach out and make some connections, and lots of different ways to get involved without going through the fire academy and having people tell you not to suck today. There's lots of little ways to be a part of it, seeing support, and I call it neighbors helping neighbors. And it's rewarding, it's fun, it's exciting. Training and equipment is often provided everywhere. And maybe it's time to add a new suit to your wardrobe. All right, a couple other things. We're kind of pushing 12:45 here, it looks like. Uh, Fluid creep. I've talked about the fluid prescription, the volume prescription, and picking the right combination of electrolytes and buffers. But one of the areas that's gained some attention in human medicine, and I think we've got an opportunity to look at this as well, as this fluid creep notion, which is that a lot of our medications are diluted in sodium chloride. Our antibiotics. Many of our flushes are often sodium chloride. A lot of our patients are on multiple CRIs, getting multiple injections, anti-nausea medications, antibiotics, analgesics, motility agents, what have you. And all these medications are flushed repeatedly, and central lines that get flushed and after blood samples, et cetera. And there's volume, and volume that's associated with these practices, which again, maybe in larger patients is better tolerated and is not as significant, but it's worth having a look and maybe even just documenting in your own practice how much flush is going into some of these patients. In the small chihuahuas and cats and animals of that size, it probably accounts for a pretty significant amount of fluid accumulation in these guys. And the phrase fluid creep in the human literature is associated with or kind of attributed to two different elements of this. One is the volume, and the other is the creeping of electrolytes, sodium and chloride to be specific. So we'll talk about that for a minute too. So be aware of the fluid creep from a volume standpoint, and questions out there: should we be considering transitioning to maintenance fluids? So those lower sodium chloride, more free water fluids, as well as volumes. Once a patient is resuscitated and we're at the stabilization phase, and Doctors Langston and Gordon touched on that in the Frontiers article, and it's present in every article I can find on acute kidney injury and how to best support these guys in human medicine. The goal is to maintain euvolemia, not to push. And they definitely talk about transitioning after you've replaced what is lost, and the need for salt, sodium chloride, and electrolytes and all the rest of that. Then transitioning to an enteral water maintenance plan, if at all possible, in their patients, and backing right down off of the intravenous fluids, going with a more physiologic approach. Not sure that we can achieve that necessarily, because our patients don't often drink on their own, but it's something to kind of, I think, take note of, and see how they're doing it in human patients, and how can we modify that and think about that to better individualize our plan for our guys. So we talked a lot about volume, and volume has its downside. We also should look at what's in those fluids, and the rest of the drug. And sodium is a newer consideration. Maybe it just hasn't gotten as much attention. Chloride has gotten a lot of attention, and we're going to talk about both of these two electrolytes in our fluids and these drugs. And the sodium load we provide now, sodium chloride with its 154 millimoles per liter of sodium and chloride is certainly an excess amount of salt load. But even our balanced or buffered electrolyte solutions, our plasmolite Normar with 140 of sodium and our LRS with 130, these are fairly super physiologic doses of sodium compared to what we would take in on a daily basis dietary wise. And in over evolution and development time, the kidneys are, the goal, one of their big jobs is to maintain volume status and respond to hypovolemic states by enhancing sodium reabsorption and water retention. And that is something the kidneys are really, really good at. They're not as amazing at getting rid of high sodium loads as we ingest them, or as we iatrogenically administer them in our replacement fluids. or replacement crystalloids. And so it's something again that's starting to gain a little bit of attention, and I think it's probably something for us to think about as well when we start, maybe considering making that transition from a replacement saltwater prescription to a more physiologic free water prescription, or some combination thereof. This was going to be a fun one. I was, gonna see if we'd get some good input here. But again, next time I promise I'll get the kinks worked out of the polls here. But we've got some options. Should we be encouraging access to enteral water more? I think we probably give bowls of water to all these guys. Is that going to combat the salt load? Should we be changing to hypotonic fluids once our volume status is stabilized and we're in that past the optimization resuscitation phase and into the stabilization phase? Or do we just follow our serum sodiums and modify our fluid prescription accordingly? And let's not get ahead of ourselves and kind of complicate matters. Let's watch what our sodium does, and we'll add in some free water in response to that. I don't have the answer. Food for thought, something to think about, and certainly something I'd love to have ongoing conversations with folks about. The chloride in replacement fluids has gained there's a ton of recent research in human critical care and resuscitation and fluid therapies on the benefit or detriment of sodium chloride versus our buffered electrolyte solutions. And while we reach for sodium chloride in veterinary medicine, it would seem for specific indications, sodium chloride is probably half the cost of the buffered electrolyte solutions, and it's what a lot of human physicians have known over time. Normal saline gets it's the first thing they grab out of the cupboard when they're fluid resuscitating patients, and ultimately, volume. In really hypovolemic patients, we've got to restore volume, and maybe what we pick is not as important at the beginning of things, but maybe there's some opportunity to better titrate the electrolyte composition and the buffering content as we go through the different phases of resuscitation. But why chloride has potential negative effects has to do with, I promised I was going to get back to tubuloglomerular feedback from a number of slides ago. But again, the kidneys being as smart as they are, this is a single nephron here, and we're seeing the tubule kind of come back up to its parent glomerulus at the center here. And this is in response to a decreased flow, and the sodium potassium 2 chloride receptor in the macula densa is sensitive to the chloride content of flow that's delivered to this part of the tubule. In response to decreased chloride delivery, we see a response increasing renin-angiotensin 2, as well as afferent arterial vasodilation in response to markers and messengers that helps increase flow to that parent's glomerulus to maintain renal blood flow and maintain single nephron blood flow and GFR. When we deliver too much chloride to the macula densa, those sensors have the opposite effect, as you would imagine. We see decreases in or absent of renin-angiotensin 2. So we say, hey, we're getting too much flow at this point. And we see increased thromboxane and adenosine, which leads to afferent arterial vasoconstriction, which leads to decreased flow and blood delivery, and therefore decreased GFR often to that nephron. In response to too much chloride being delivered. So we've got a patient with a kidney injury or whatever other inflammatory condition. We're already at risk for damage to the kidneys, and we want to maintain renal blood flow. We want to maintain GFR, and we're sending all this chloride, and we're saying, hey, there's too much coming. Let's shut this down. Let's clamp down on this. So there's some physiologic reasons why excess chloride delivery would be a bad thing. So a number of studies over the last years on the human side have looked at, hey, is saline bad? Should we be using balanced electrolyte or buffered electrolyte solutions? And there's been a little bit of a mishmash, unfortunately. And it's hard in all these studies. I mentioned earlier, when is the baseline? When should we start accounting for what fluids we give? And a lot of these studies start their time point 0 is when they're patients are admitted to the ICU. So it kind of ignores all the potential resuscitation fluids they got in the emergency department. So you'll see these two, the SALT-ED and the SMART studies, both found that secondary outcomes were made worse using saline versus a balanced electrolyte solution. Whether that's persistent elevation in creatinine, whether that's the need for renal replacement therapy, although that one didn't achieve significance there, or just major adverse kidney effects in general in the SALT-ED study there. No, this is out of order there. I apologize. More recently, I'll draw your attention to the BASIC study there, and that's what that previous slide was showing. In the BASIC study, where they compared saline again with balanced electrolyte solutions, they documented very well that the patients receiving saline had higher serum chloride levels. That makes some sense, given the amount of chloride that's in there. This multi-center, pretty large, randomized, controlled, double-blinded study, very nicely set up, as probably a better standard of trial compared to some of the predecessors here, although they were all pretty good studies as well. These guys unfortunately didn't see any difference in 90-day survival between saline and buffer electrolyte solutions. No difference in the incidence of AKI, need for kidney replacement therapy. And so out of basics, there's this, we're kind of back to, there's this shift in human medicine towards let's use buffered electrolyte solutions over saline. Now this came out and there's maybe some question to that, but bears question in our patients as well. And we use more balanced electrolyte solutions than not. But having said that, there's still a fair bit of chloride in those solutions as well. And this is kind of all coming back around to maybe we should consider changing from those replacement fluids to hypotonic free water fluids, as we're moving through the phases of fluid therapy in our kidney patients. Changes in the volume in our fluid prescription. You know, we're battling the dogma that increased IV fluid volume is needed to diurese patients with kidney disease. The perception that push more fluids if you've got an oligoanuric patient, and you know, we certainly have to make sure that their volume repletes before we make that statement. But there's a push and there's a push and there's a push, and maybe we need to get the message out that euvolemia is what we're after, not aggressive diuresing of these patients. Let's find that sweet spot. All right, so we talked about these already. I'm going to just I'm running out of a little bit of time here. So how should we modify our fluid prescription? Is 2 times maintenance with a balanced electrolyte solution, which is what I see in a lot of my colleagues until they're better or dead, or other outcomes. Should we resuscitate with a balanced or buffered electrolyte solution until euvolemia, and then switch to treating insensible losses with a hypotonic fluid and sensible losses with a balanced electrolyte solution? Should we just continue with the BES and monitor serum electrolytes and change the free water content of our fluids based on that? I don't have the answer, and I think there's probably some recipe in here that might make some sense. Beware of the creep. How do we monitor it? I've got probably 10 more slides I wanted to touch on ultrasound monitoring and point of care, but we're running out of time, so I'm going to just come through here and just mention to pique your interest, a new point of care ultrasound technique called VEXUS, the venous excess ultrasound. That is gaining a lot of evidence behind it and a lot of interest on the human side of things. And it looks at 4 points on the venous side. We're talking about the inferior vena cava, or for us, the caudal, hepatic vein flow, portal vein flow, intrarenal vein flow, and using this to really look at the venous side and say, you know what, we've hit the limits of what we should be doing as far as volume goes, and let's not make this situation worse than it already is. Let's look at some of these characteristics of these different vessels on the venous side, and let's pull back, or even they're using higher scores as indications of increased right atrial pressure as a guide for them to implement diuretic treatment and get into that evacuation phase as well. So do we have anything like that in veterinary medicine? There are a couple of papers that have looked at caudal vena cava size, both just in healthy dogs and then in blood donation dogs, but we're certainly not to the point where the VEXUS score is on the human end. And food for thought, maybe some evidence, maybe somebody's already doing some research out there. Somebody's doing some practical use of it. I'll look at the caudal vena cava in some of my patients when I'm trying to assess volume status. Maybe there's an opportunity to develop some of that system for our use in veterinary patients as well. And with that, I will take a breath here and love to open it up to any comments, thoughts, sharing, or questions.
Thanks, Jethro. That was really fantastic. Anybody have any questions? I have a question slash thought. The one thing I've wondered is because dogs and cats have higher serum chloride concentrations than humans, particularly cats, could that make them more protected against those adverse risks of getting excessive chloride and that adverse tubuloglomerular feedback? I wonder if maybe they might be a little bit less at risk, but still I think we have to acknowledge the fact that our fluid prescriptions still administer 15 to 25 times the amount of salt that they should receive in a day. So maybe that difference in their plasma sodium concentration is negligible when they're getting bombarded with such a high quantity of salt. But I've wondered if maybe our patients might act a little bit different, and especially since the human trials aren't 100% conclusive, maybe our patients are maybe okay. Personally, I'm still using, I use more LRS than anything else to try to avoid it, but it's just a thought that I had that I haven't been able to come up with a good answer.
Yeah, I'm certainly. I mean, the mixed bag of results here makes it hard, from making statements about the human end of it. And I'm always cautious to the body of evidence, from a lot of these topics is pretty robust on the human end of it. But our cats and dogs aren't small people, right? So how that translates, I don't know. That's an interesting thought. That's maybe they're better protected, or maybe it's not an issue with the chloride at all, as they're the mixed bag and the people is showing, or potentially showing. But I agree. I mean, I think the sodium content is where I worry a lot about these guys. I throw the chloride in there because I think the physiology is really cool, and the TGF process is really interesting. But physiologically, I mean, once we've replaced what they've lost, which might be high in salt or high in sodium, um, you know, should we be giving them what they would have physiologically be taking in? And that's much more of a water than a salt water.
Yeah, very good points. Shelley brought up the comment that we should maybe think about in a future session talking about outpatient fluid therapy and sub-Q fluids, how that can still be a great volume of salts given to patients, and how that might best be managed. So I think that would be a great session. And Anna had asked if the interns, if the principles discussed here would apply to acute on chronic patients or decompensated patients in the ICU. And I think I would say, and correct me if I'm wrong, Jethro, but I would think absolutely. These are probably generalized to pretty much every patient, and even more so probably in those that are critically ill, and those with decreased kidney function are probably those that are going to have the potentially greatest risk for adverse effects. But I would say these principles are nearly universal to all hospitalized patients. But I'll let you get the final word in there, Jethro.
Yeah, I would just echo what you just said, which is, yeah, this is universal. I mean, certainly because of the audience and because of my appreciation for the kidneys, I focused a lot on that. But absolutely across the board, I think our awareness of the fact that the fluid prescription is not benign. It deserves our well thought out and titrated and individualized attention to what our specific patient needs are. One size doesn't fit all. One disease doesn't get treated the same as another. But absolutely, I think these principles would apply to all those different acute on chronic or decompensated chronic patients as well. Couldn't agree more. And yeah, I didn't mix it in here. I had some thought about kind of sprinkling in physiologic water, at home via e-tubes versus the sub-Q salt water that we give these guys. But it's another great point and bears more consideration and discussion for sure.
And Kelly had shared that with an illness herself, she had developed fluid overload. So it's, you know, she has the unfortunate experience of being able to say it from firsthand experience. And it's something that obviously they still battle in people. And I guess it makes me feel a little bit better that it's a problem with them. So, you know, we're not that far behind that it's a problem with us as well too. But it is remarkable having these types of discussions, and you talk to internists, criticalists, just patients that deal with a lot of hospitalized patients, and sometimes they will say, you know, we don't see volume overload. We just don't see it, and that just can't be true. You know, I think it's if it's not on your radar, you're not thinking about it, then you might not recognize it, because you know a lot of fluid overload can happen before those patients develop ascites or gross edema. So I think the more we can talk about it, the more recognition, the better. The more we can start to move forward and try to maybe repeat some of these studies in our patients as well too.
Yeah, that's just it. I mean, you hit on you know what I said. You know, anybody can say, yeah, serous nasal discharge and peripheral edema and maybe pulmonary edema. You know, it's happening way before any of those outward signs are readily noticed. The edema that's forming and elsewhere in the body. So yeah, if you're not if we're practicing conservative individualized fluid prescription, you know, management, great. Then maybe we are avoiding some of that. I think to some degree it's inevitable, whether you're cautious and judicious or just kind of pouring fluids willy nilly at folks or at cats and dogs in our case. But yeah, I think it's happening below the surface in those hidden places, and that's what I'd love to talk more about and raise awareness of.
Great. Well, thank you, Jethro. That was a fantastic presentation. That was a deep dive into the physiology and the human trials, and I know that was a lot of work. So thank you so much for putting that together. Thanks, everybody, for coming in and joining this last session of the year. I thank you all and hope you all have a fantastic holiday season. I'll go ahead and stop the recording.